You're listening to Medscape's In Discussion series on type 2 diabetes, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Carol Wysham. Dr. Wysham is an endocrinologist at Rockwood Multicare Health Systems in Spokane, Washington, and a clinical professor of medicine at the University of Washington. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Carol Wysham. Welcome to Season 3 of Medscape Type 2 Diabetes podcast series. Today, we'll discuss new insights into heart failure in type 2 diabetes. First, let me introduce my guest, Dr. Christopher Kramer. Dr. Kramer is a cardiologist at the Heart and Vascular Center at the University of Virginia Health. His areas of expertise are hypertrophic cardiomyopathy and cardiovascular imaging, including echocardiography, cardiac magnetic resonance imaging, and cardiac computed tomography. He is the George A. Beller Lantheus Medical Imaging Distinguished Professor of Cardiovascular Medicine and the Chief of the Cardiovascular Division at UVA Health. Dr. Kramer, welcome to Medscape in Discussion Type 2 Diabetes podcast.
Thank you for having me, Dr. Wysham.
Well, I'd like to start out by having you discuss the increased risk of congestive heart failure in patients with type 2 diabetes.
Yes, as it turns out, the incidence of heart failure is 2.5-fold increase over a group of patients without type 2 diabetes. The risk factors that increase the likely prevalence of heart failure in this group include diabetes onset at a younger age, underlying coronary disease, hypertension, elevated body mass index, so obesity, and poor glycemic control. Other markers associated with obesity, including increased waist circumference and fat mass, are also associated with a higher incidence of heart failure in type 2 diabetes. As it turns out, type 2 diabetics make up 35 to 45% of all heart failure patients, with a higher incidence in patients with heart failure with preserved ejection fraction, as opposed to those with reduced ejection fraction.
Mentioning that, I found it interesting when I learned that there's a marked increase in the percentage of patients with heart failure who actually have preserved ejection fraction. You want to comment on that?
Yeah, definitely higher incidence in preserved ejection fraction. The combination of obesity, diabetes, and hypertension definitely lead to that higher incidence.
Would you give us some insight into the pathobiology of why heart failure occurs in this population?
Yeah, it's complicated in part due to the hyperinsulinemia associated with type 2 diabetes. Inflammation is a major part. Increased fat mass around the heart leads to increased adipocytes, the release of adipocytokines, which are hormones that lead to inflammation and hypertrophy, as well as oxidative stress. All of those issues lead to an increased incidence of heart failure. The other major issue that is brought on by obesity is reduced natriuresis, and that, along with diabetes, can lead to a volume overload state.
So that's actually really interesting. Is there a role of microvascular dysfunction and disease that we frequently see in patients with longstanding diabetes?
Absolutely. Microvascular dysfunction is a major issue leading to heart failure. There can be disorder of the microvasculature within the heart muscle, leading to abnormal myocardial perfusion reserve, and that can lead to ischemia in the absence of epicardial coronary artery disease. So without atherosclerosis in the major epicardial arteries, there still can be ischemia in type 2 diabetics. Now, often they have concomitant epicardial coronary artery disease as well, but you can have, due to microvascular disease, ischemia and abnormal perfusion reserve without epicardial disease.
Great. Well, thanks for that. So you are probably aware that the American Diabetes Association has recommended routine screening for congestive heart failure in patients with diabetes. Obviously, there are patients who have symptoms, and that makes sense. But can you just comment on your opinion about, is it appropriate to screen and who to screen?
Yeah, I think Symptoms are obviously going to be the most important tip-off as to who to screen. And I think talking to your patient about exercise intolerance is the single most important question one can ask in terms of how far they can walk. Can they go up hills? What happens when they walk their dog? Can they go upstairs? Any change in their ability to tolerate exercise should be a tip-off. I think if the patient's completely asymptomatic and able to do significant exertion without symptoms, I'm not sure that screening those patients makes sense. But anyone with any symptoms, and certainly older patients, I think then screening may make more sense. There's discussion about chest X-ray and BNP. Chest X-ray, in my mind, is insensitive for heart failure, and especially in this population. So that's a very late finding in heart failure, pulmonary congestion and curly B lines or enlarged heart. That's a very late finding. Elevated BNP is probably the best single screening test for heart failure. Now, the problem with that, with BNP alone, is that it can be falsely low in obese patients with diabetes. So obesity actually lowers the BNP. So BNP is probably most helpful in the non-obese diabetic, and you can get fooled in the obese diabetic, which was one problem with that biomarker.
But if you have an obese patient with an elevated BNP, it's something that probably needs some follow-up.
Absolutely.
You think it's appropriate for the primary care or endocrinologist to go ahead and order the echo while they await the cardiology consult?
I think it's reasonable. Certainly, if the BNP is elevated, I think getting an echocardiogram would be the first test we would order. And it's always helpful if that's done by the time the patient comes to see us.
Well, let's move to treatment of congestive heart failure. And I know that there's a lot of interest in the incretin therapies, the GLP-1 receptor agonist or the dual agonists in people with type 2 diabetes and comorbid congestive heart failure. Can you tell us about the known effects at this point?
Yes, so that's something I've actually been involved in the SUMMIT trial and studies in obesity, some of the patients with heart failure. So I'm happy to comment on the use of incretin therapy. So as you're aware, these incretins the mechanism is that they regulate insulin and glucagon secretion by the pancreas. They can actually promote proliferation of the beta cells. They're associated with reduced inflammation, reduced oxidative stress, and from a cardiac perspective, they can actually improve LV contractility, reduce systemic vascular resistance, and reduce end diastolic pressure. They have a lot of potential benefits in the heart, and more recently, clinical trials have shown us that they're especially beneficial in patients with heart failure with preserved ejection fraction, which, as we've spoken about, diabetes is a major risk factor for that condition. And heart failure with preserved ejection fraction makes up about half of all patients with congestive heart failure. And we know it's the number one morbidity and cause of hospitalization in the US, so a major hit to the cost of healthcare. In HFpEF, about 50 to 60% of patients are obese and 40 to 50% have type 2 diabetes. So in terms of how incretins work, they reduce weight. Most recently, the two major trials in obesity and heart failure with preserved ejection fraction are the STEP heart failure and the SUMMIT trial. In the STEP heart failure, there was a diabetic subgroup that was studied of 616 patients that were randomized to either semaglutide or placebo, and the active therapy group was associated with, it was not because of the size of the study, it was not an event-driven trial, it was driven by symptoms and quality of life. Turns out the active therapy with incretins, so the semaglutide, was associated with an increase in the Kansas City Cardiomyopathy Questionnaire score, which is a quality of life marker. Body weight fell by 10%. The overall win ratio was positive, and the marker of inflammation, CRP, probably the best biomarker of inflammation, fell. So certainly evidence in diabetics with heart failure with preserved EF that incretin therapy is associated with those patients feeling better. So that was the first step. They feel better, able to do more exercise. Then along came the SUMMIT trial, which was presented At last year's American Heart Association meeting, there were 4 presentations, one of which was mine, but Dr. Milton Packer was the first author of the New England Journal paper, which was the main principal findings of the SUMMIT trial. So the SUMMIT trial was over 700 patients with obesity and HFpEF, not all diabetics, but there was a good portion of patients who were diabetic within that population, who were randomized to tirzepatide therapy versus placebo over the course of up to 2 years, but the trial itself was a 1-year event-driven trial. The main outcomes were combined endpoint of cardiovascular death and heart failure events, primarily heart failure hospitalization. And the active therapy with tirzepatide was associated with a hazard ratio of approximately 0.5 compared to placebo for that combined endpoint. Now, most of the difference there was in cardiovascular hospitalizations and cardiovascular events, requirement for intravenous diuresis. There's actually numerically a slightly higher incidence of death in the treatment group, but it was not powered for deaths. There was no statistical difference. And so most of the difference was in heart failure hospitalization and heart failure events.
That's really important. What is your perspective on whether or not these studies are robust enough to get an indication for these medications for treatment in heart failure?
Yeah, I feel strongly that these medications are very powerful, probably one of the best therapies we have, especially for HFpEF, which until the last 2 or 3 years, we really had no therapy for. Now we have 3 classes of therapies that are beneficial in HFpEF. Those include SGLT2 inhibitors, the renin-angiotensin receptor antagonists, specifically finerenone, most recently shown at last year's ESC and published in the New England Journal, and now the GLP-1 agonist or incretin therapy. And if you'd like, we can speak some more about the mechanisms of how tirzepatide in particular benefited patients with HFpEF and obesity.
Yes, please. I'd be interested in hearing that. I'm sure the audience would as well.
Yeah, so there were 3 separate publications after the AHA simultaneous with the presentations. Dr. Barry Borlaug published a paper on the hemodynamic and biomarker findings associated with tirzepatide therapy in HFpEF and noted that active therapy was associated with a fall in blood pressure, so it had an antihypertensive effect, a fall in blood volume, it was anti-inflammatory, CRP fell, it improved renal function, GFR improved, and urine albumin to creatine ratio fell. There was a fall in biomarkers, both NT-proBNP and troponin T. So clearly a benefit in terms of the hemodynamics, inflammation, and basically myocardial injury with BNP and troponin, as well as improved renal function. So across the board, very positive effects in these patients who were treated with active therapy with incretins. And that was published in Nature Medicine. The second paper in Circulation by Dr. Michael Zeil showed that in addition to the improvement in reduction in cardiovascular heart failure events, there was improvement similar to the STEP-HFpEF trial with semaglutide. With tirzepatide, there was improvement in KCCQ score, as I mentioned, the Kansas City Cardiomyopathy questionnaire score, so patients felt better. There was an improvement in the 6-minute walk distance, so patients not only felt better, they were able to walk further. There was an improvement, a decline in New York Heart Association class, and a reduction in the need for associated heart failure medications. So not only in Dr. Borlaug's paper showing improved hemodynamics, but now improved quantitative measures of patient functionality. Across the board, tirzepatide was beneficial in this patient group. And then the last paper was my paper published in JACC. As you mentioned at the top of the podcast, that my expertise is in cardiac magnetic resonance imaging, and I led the CMR sub-study of the SUMMIT trial, which was a sub-study of 106 out of the over 700 patients who entered SUMMIT, and they had a cardiac MR at baseline before entering the study, and then 1 year at the end of the study, again, half treated, half placebo. And importantly, really helped delineate the mechanism of how incretins work in HFpEF. So there were 2 important differences. One was in the treated group. One was a reduction in LV mass by about 10%. So it has an anti-hypertrophic effect. It's probably multifactorial due to the reduction in blood pressure, the natriuresis. So basically the load reduction that occurs with incretin therapy. The other major difference was a marked reduction by about a third in pericardiac adipose tissue. So there's two types of pericardiac adipose tissue, or two components. One is epicardial adipose tissue, and the other is pericardial adipose tissue. So that's adipose tissue separated by the pericardial layer. So epicardial adipose is between the epicardium and the pericardium, and pericardial adipose is external to the pericardium, between the pericardium and the chest wall. Most of the adipose tissue is actually in these obese patients was visceral fat, namely pericardial adipose tissue. About 75 to 80% of the fat was outside the pericardium. And that's where we saw most of the decrement in adipose tissue with active therapy, was in the pericardial fat, the largest component of pericardiac fat. So this helps us understand, again, the mechanism of how incretin therapies are working. So as the patient is losing weight on these therapies, pericardiac fat is melting away. That reduces the adipocytes, reduces the adipose cytokines, the pro-inflammatory, pro-hypertrophic paracrine cytokines that are released by the pericardiac fat. And this leads to the overall hemodynamic improvement.
Really interesting information. So, how would you recommend placement of the GLP-1 receptor agonist or the dual agonist in the management of patients with congestive heart failure? Probably you mentioned the three different medications. Do you think they should be started concurrently, or do you have any order of which you think might be more important?
Yeah, I think that still needs to be worked out in HFpEF. We've really focused on the benefit of this class of medication in HFpEF. Their benefits in HFrEF, or reduced ejection fraction, are less clear. And so I think in type 2 diabetes and obesity and HFpEF, they have clear benefits. There's emerging data that the combination of SGLT2 inhibition and GLP-1 agonism may be complementary, may be additive, and the combination may be even better. I think we need more studies, and with one, the other, and the combination. I don't think you can placebo control them at this point, but looking at is combination better than either one will be important in this space to understand. I think both SGLT2 inhibitors and GLP-1 agonists can be added to the renin-angiotensin or aldosterone blockade with finerenone or spironolactone, although that Top Cat study from years ago was a negative study, but it's probably a class effect, though finerenone certainly has the stronger data associated with it. All three classes of drugs are beneficial now in HFpEF. The order of how to stack them upon each other, I think, is less clear. And I think we'll find out in the coming 2 to 3 years of whether there's a cadence of which to start first and how to add them on. But certainly in the diabetic, where you're looking to control glucose, in my mind, SGLT2 inhibitors and GLP-1 agonists are preferable over the renin-angiotensin system blockade medications, because you're treating the underlying disease in addition to treating the heart failure with preserved ejection fraction. You're allowing weight loss as well as the benefits in terms of the effects on hyperinsulinemia, et cetera.
So, is there anything out there in terms of research or directions that you're excited about coming up in the next few years?
Yeah, I think more information about looking at subgroups and understanding in all these trials how diabetics fare versus non-diabetics. I can tell you that there's unpublished data from Summit that suggests that tirzepatide have the benefits were similar in diabetics and non-diabetics. So I think that's reassuring. We know that the weight loss in diabetics is somewhat attenuated relative to non-diabetics with GLP-1 agonists, but the benefits of at least tirzepatide appear to be equivalent, and also with semaglutide in the STEP-HF diabetes study, that both agents have been shown to be beneficial. So I think understanding the mechanism and then understanding the cadence of which drug to start first, second, third, how to put them together. We now know in heart failure with reduced ejection fraction that there are 4 pillars of therapy, that we want to get all 4 medications started in these patients, and we start them at the same time. Research over the last decade has helped us there. Now with HFpEF, we have to do the same studies. And that's, I think, the most important step in the next 5 to 10 years is understanding, you start them all at once, you start GLP-1s first, you hold on the MRAs, et cetera. So I think we have a lot to learn, and it should be exciting over the next few years to learn that.
Coming from the endocrinology standpoint, because of the high association of kidney disease in patients with heart failure, likely the patients are already going to be on a GLP-1 and an SGLT2 inhibitor before they even hit the door of the cardiologist's office. Well, I want to thank you for a very, very interesting conversation about heart failure and type 2 diabetes and the role of the incretin therapies in management, particularly of heart failure with preserved ejection fraction. I want to thank the audience for tuning in. Ask them to please take a moment to download the Medscape app to listen and subscribe to this podcast series on type 2 diabetes. This is Carol Wysham for Medscape in Discussion Type 2 Diabetes Podcast.
Thanks for listening to Medscape's In Discussion Type 2 Diabetes podcast series with our host, Dr. Carol Wysham. Be sure to look for more In Discussion episodes wherever you'll get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on type 2 diabetes.